Hello. I'm extremely sorry not to be able to be with you this afternoon. I arrived at the airport to a chaos of delayed and cancelled flights, with people, lots of shouting and food vouchers everywhere. So please accept my apologies on behalf of the airlines. I don't have any financial disclosures to make pertinent to this presentation. However, 3 of the 4 offspring are now earning independently and only 1 remains at university. The financial burden is definitely easing. So back to the question. The answer is anti-VEGF treatment making panretinal photocoagulation redundant is no. So now let's ask why. After diagnosis of diabetes mellitus, we're used to this following disease progression. During the majority of the disease, the management falls to the patient, to the physician, and to retinal screening, if you have it. Towards the far end, the patient may develop macular edema or proliferative diabetic retinopathy, or both. And this is the point where we intervene. In this session, we're concentrating on proliferative diabetic retinopathy. So we just alter our line like this. The biochemistry of diabetes is actually very complicated, indicated by the large number of mechanisms that are listed here. But all of these, in various proportions, lead to diabetic eye disease, and a subset of that is diabetic retinal disease, which is now understood to be both neuronal and vascular in nature. And the treatments for proliferative diabetic retinopathy we know. These biochemical changes lead to the anatomical problems of pericyte loss, thickened basement membranes, damage to endothelial cells, and leukocyte adhesion. And ultimately that leads to retinal non-perfusion, an upregulation of VEGF release, and increased vascular permeability. And when the non-perfusion reaches a threshold of about 300 millimeters squared, that is when proliferative retinopathy can occur. So the progression of the visible signs of diabetic retinopathy follow the development of retinal non-perfusion. Here are a few of the many references which are related to this finding. In terms of treatment at the stage of proliferative retinopathy, we have very good evidence that PRP works. We also have very good evidence that anti-VEGF injections work, and that anti-VEGF injections result in better visual acuity outcomes than with PRP. There are data, however, that indicate if the anti-VEGF treatment does not continue, the patient can do badly. I do encourage everybody to read this excellent article on the preferred practice pattern. So how about anti-VEGF treatment in non-proliferative diabetic retinopathy? Well, the studies using aflibercept show a significant reduction in the proportion of patients reaching diabetic macular edema or proliferative diabetic retinopathy. The Panorama study showed that 65% of people had a 2-step reduction in their diabetic retinopathy severity score, and similarly with ranibizumab, the proportion of patients reaching proliferative retinopathy was significantly less. So actually the treatment with anti-VEGF therapy looks really good. But let's think about the underlying problem of retinal non-perfusion, because it is that which leads to the clinical signs we observe. It turns out there are 2 types of non-perfusion. Vessels can be occluded by leukocyte plugs, and these ones are potentially recoverable. The second type are vessels that are permanently occluded, and there is irrecoverable loss. So it seems sensible to suggest that non-perfusion will begin with potentially recoverable capillary vessels, and as the disease progresses, the proportion of irrecoverable vessels will increase. So we can ask then, what effect does anti-VEGF treatment have on retinal non-perfusion? Well, the recovery study and some others have shown that there might be some reperfusion following anti-VEGF treatment, but the statement in the paper is that this was not the case in most of the patients. In the group with aflibercept administered monthly, the non-perfusion did not increase, whereas with the group treated with quarterly dosing, the retinal non-perfusion increased by a mean of about 60 millimeters squared. In the second year of the study, when the treatment arms were swapped over, the area of non-perfusion increased to a mean of 400 millimeters squared in both groups. And I remember that the threshold for triggering proliferative retinopathy is about 300 millimeters squared. And there is some evidence of reperfusion, but that is actually present in the natural history of the disease. It's also been documented after panretinal photocoagulation, and we know a little bit of reperfusion has been documented with anti-VEGF dosing, but in all of these, it was small areas at best. So that suggests to me that the majority of the vessels in eyes with significant retinopathy actually have permanently occluded vasculature. So to summarise, I just want to quote the paper from Charles Wyckoff, where he says, while intravitreal dosing can dramatically decrease the extent of visible vascular abnormalities associated with diabetic retinopathy, reperfusion of areas of retinal non-perfusion is not typically observed in these eyes. So treatment with regular anti-VEGF, one will obtain a cosmetic improvement in the clinical signs, but the retinal non-perfusion will remain and over time will worsen, and it will worsen to beyond the area needed to result in proliferation. We have to remember that we have a very large number of patients to care for, and that anti-VEGF treatment with its current mode of administration by injection of relatively short half-life agents means that it is not possible to adopt this at the moment. We would create a group with cosmetically improved retinae, but lapses in treatment, and that will happen in any service that deals with a large number of patients, that might well result in very aggressive proliferative disease, which we would then treat with PRP and vitrectomy, most likely. So I would say, don't get caught in the anti-VEGF trap. It may be that in the future, anti-VEGF treatment will become dominant, and perhaps, however, would best be started early in the retinal disease, where vessels are recoverable, and then non-perfusion would need to be monitored by regular fluorescein angiography, not clinical examination and colour photographs, and some would still need panretinal photocoagulation. So I've adjusted the image to include vague time points about where anti-VEGF treatment would be suitable and where it is too late. We await much longer acting agents or sustained release devices or in-eye production methods. So the current answer to the question is no, and now I hope you understand why. Thank you very much for your attention. I apologise again for not being with you this afternoon.